A very good morning to all of you. Welcome to the CPD webinar series organized by Society for Health Research and Innovation. First, let me introduce you with the housekeeping rules. The webinar link will be available from 9 a.m. to 9:50 a.m. to you to join in. No late attendees will be entertained thereafter. Each attendee should have been attended till the end of the webinar to obtain the certificate for CPD points, and the CPD points are strictly adhered to the NCCPD guidelines. These are to improve and maintain the standards of the CPD programs conducted by Society for Health Research and Innovation, and thank you in advance for the strict adherence to the CPD regulations. You can ask questions at the end of the webinar, and also you can type the questions in the chat box. And if you have very specific questions, you can email us on office313@gmail.com. So today's topic is how to manage common gynecological complaints. The guest speaker for today is Dr. Dharshana Somirathne, consultant obstetrician and gynecologist at Base Hospital, Walasmulla. Over to you, sir.
Right. Thank you, Samira. Okay. Good morning to you all. As Samira explained, introduce about myself. I'm Dr. Dharshana Somirathne, consultant obstetrician, currently working in Base Hospital, Walasmulla. Thank you very much for the GMO3 arranging or inviting me to conduct this webinar about common gynecological presentations to GP setup or settings. I'll try to recap basics presentation, gynecological presentations, how they present and how a GP can manage and which level a GP can manage most of the complaints. Okay, I'm going to start with kind of a brief, introduction, like, it's a kind of symptomatic presentation. It's a spectrum, like you might get a small girl like age of 4, 5, ranging to extreme age like maybe 80, 90. This is a spectrum that you all get kind of complaints. I'll start with puberty and pubertal related complaints. And before I talk about this age group, I think better to understand basic physiology behind the puberty. You all know about the boys and girls. They have the pubertal stages, but this is related to the women health, and I'm talking about the girls' pubertal stages. There are 4 spurts, 4 domains we talk about puberty as a stage: the growth spurt and the breast development, pubic and axillary hair development, and menstruation is the last event. And you all can remember your basic physiology about the Tanner stage. I'm not going to talk about much on that. Just a recap about how the pubertal stages are. Like, again, the growth spurt, breast development, pubic and axillary hair development, and the last event is menstruation. The precocious puberty, this is very, I would say, kind of uncommon presentation to the GP setup, but anyway, it can present because sometimes the parents might bring their girl or the daughter to you saying that, doctor, that my daughter is still age 7, but she's starting menstruating and she has got developed, the breast development, pubic hair, and basically she looked like now adult girl. And now this is a problem. Like, technically we define precocious puberty. Any girl shows secondary sexual characteristic and start of menstruations at prior to age of 8 is a problem. Mainly the HPO axis is the issue, and for that we had to roll out the possible causes, maybe some syndromes, or maybe idiopathic. There's a syndrome called McCune-Albright syndrome. It's a genetic disorder, and in addition there might be a tumor of the HPO axis, cerebral tumors, or any exogenous or endogenous estrogen. These are the main causes for the precocious puberty. As I said earlier, this is not that common. This is a bit of common presentation to you all in GP, like a delayed puberty. Actually, the parents might bring their girl saying, doctor, now she's still 14, she has not, she's smaller, not getting enough height compared to her colleagues in the school or the classroom, she's still shorter, not developing breast and no pubic hair, and then kind of this type of complaints might be commoner. And then you have to get the full history. It's very much important about general health, and then any stages has started, like, you know, pubic or breast budding. And then if you can, then you have to examine, actually, if you can examine, and if you can notice some kind of breast budding, and as I said, like a tanner stage, then, you know, she has started the, you know, the pubertal process. In addition, you have to ask about the chronic illnesses and the family history any history of constitutional, you know, delay. And these are the things that you have to get the proper history and then do the examinations about the delayed puberty, and then you can understand whether there's a problem or she has already started the process. But again, the complaints that they might come up with amenorrhea. They might bring the child to you, say, doctor, my girl is now 14, not started menstruation, or my girl is now 17, not started menstruation. Again, like primary amenorrhea, they define like any girl who has got sexual characteristic, even at the age of 16, if she's not menstruating, there's a problem. Again, any girl without sexual characteristic at the age of 14 is a problem. And then like that, if you see this type of presentation, then definitely something wrong with the HPO, we call as eustress, hypothalamo pituitary or uterine problems, and then you have to definitely refer to the gynecologist for further evaluation. These are the few causes that for the primary amenorrhea, like anatomical abnormalities, like imperforated hymen, imperforated hymen, and then some hormone, some genetic problem like 5-alpha reductase, androgen insensitivity, or problem with hypothalamic pituitary ovarian excess, as I said. And anyway, my message is, if someone comes with primary amenorrhea, I think best thing you should refer to the gynecologist. This is the main, I would say, like I know that many GPs are listening the lecture. You will definitely, if you see 100 patients a day, and I would say at least 10, 15 women comes with this problem, abnormal uterine bleeding. And what is abnormal uterine bleeding? Abnormal uterine bleeding is any bleeding pattern other than normal menstruations, we call abnormal uterine bleeding. And the causes are dependent on actually the age of presentation. I'm going to talk, and in this lecture, actually, I'm going to talk more about the abnormal uterine bleeding because that is so much commoner. Now, before we talk about or discuss about abnormal uterine bleeding, I think you guys should understand how the menstruation cycle works in women's body. Without understanding the basic physiology, I mean, it's not good idea to prescribe any medications to women. I know that I'm not insulting, but I have seen, you know, in my practice, some of the doctors, they prescribe, I mean, without understanding how these drugs works and what is the physiology behind that. Because some of them, they don't know, like testosterone, progesterone, how long we should give, like that. I mean, these are the, you know, commoner mistake that everyone can do if you don't understand the, you know, physiology behind the menstrual cycle. As you all know, like when we were in the second MBBS time, and then even for the advanced level, we studied the menstrual cycle. It starts with, you know, the hypothalamic pituitary ovarian axis, and then the changes happen in the ovary, and then changes happen inside the endometrium, or endometrial changes. You know that early part of the menstrual cycle, the estrogen level is low, and because of that, the negative feedback is not act on the HPO axis, and then FSH is rising. And because of FSH, more follicular generate within the ovary. And then with the increased number of ovaries, not ovaries, increased number of the oocyte, the oocyte itself produce more and more estrogen. Then what will happen with the estrogen? The endometrium getting thicker and thicker and thicker. Uh, and the initial 14 days we call like a follicular phase, or the proliferative phase when it comes to endometrium. And then at day 12 to 14, this, with the LH surge, the ovulation occur. With the ovulations, again, the corpus luteum formation start, and then progesterone level goes up. And now starting the secretory phase of the endometrium, and then it's increase the number of glands, increase the mucus changes, and then ultimately the menstruation process started. And that's how usual menstrual, basically the physiology behind menstrual cycle. But when it comes to you, like about, the complaints, they come and, tell you that, doctor, my periods are not, heavy or more bleeding, and then not regular. And anytime anyone who comes and complains about her menstrual problem, you have to get a proper detail, history of we call menstrual history. There are 4 domains we have to talk about the menstrual history. Again, the duration. Duration means how many days you are bleeding. For instance, we usually, tell like if duration was 2 to 7 days is the accepted duration, but again 7 days is a bit high. I would say like 5 days is usually 2 to 5 days is acceptable duration of the menstruation days. Again, you have to ask about the flow. Okay, now the duration, and then you have to get the understanding about the menstrual flow. Flow usually, menstruation flow. The menstrual blood is not arterial. It's arterial blood. It's not a venous blood. 80% of arterial blood. Usually, menstruations, we don't expect someone to develop clots. If someone complains clots, that means her flow has increased, because usually menstruation is not getting clots. These are the, this is the one component, flow. And then you have to ask about frequency. Frequency means how frequently you get in period. Like, is it 28 days or is it like a 30 days or 32 days, like that. But again, if I give a range of regularity, I would say like 28 plus or minus 7. That's mean 20. If someone is getting period 21 to 35 days interval, I would say that's accepted the frequency. The regularity is again, is regular. Can she predict next cycle like that? So regularly coming is the other component of menstrual cycle. And again, now I would like to take this slide for you to understand what I will do. Usually when a patient come to my practice, I will draw a line like that. Can you see that there's a line? I draw like that. And then I write April, March, February like that. I'll ask, okay, now tell me, when did you start menstruation like that? In this hypothetical case, is the end of April, maybe 5 days. I like that, right? I draw like that. And then I draw with the red pen, the pain, whether this is a first day or like that. And this is a usually normal menstrual pattern depiction of, graphically. When you see a patient in a menstrual pattern, if you used to practice this type of, the graphical, the diagram, then definitely in your mind setup, you can get understanding what is happening inside the uterus. Is it a polyp, or is it a fibroid? Is it an adenomyosis? Is it a cancer, or like that? It's a very good thing if you can practice just us writing about heavy flow, intermittent bleeding, or spotting like that. And if you can draw like that, and then you can understand very well about the physiology and the pathology behind this abdominal uterine bleeding. I will show one by one, like when it comes to adenomyosis and then the fibroid, how this, graphical, representations varies. All right. Okay. Now, the causes for abnormal uterine bleeding. Again, the figure has classified like a palm coin classifications. It's the kind of organic causes. That means the causes that you can see in your eyes, or maybe we can you can see it, we call organic, and then inorganic causes as well. Organic causes we call like palm, and then inorganic causes or like there's a causes that you can't demonstrate physically. Um, uh, palm is you start with a polyp, A is adenomyosis, and leiomyoma is a fibroid malignancy. Those are the organic causes. And inorganic ones, coagulopathy. That if someone has problem with the blood clotting issues like either intrinsic, extrinsic, or platelet disorders, any problems, it is belong to that. And then ovulatory dysfunction. This is a cases comes with annulatory bleeding type. For instance, polycystic ovary syndrome. Women, they will develop heavy bleeding, abnormal bleeding. They belong to ovulatory dysfunction. And then endometrial causes. Again, endometrial, most of the doctors confuse with endometrial causes like endometrial cancer. No, it's not really. I don't know whether you will remember now we don't talk anymore that word called dysfunctional uterine bleeding. I would like to take you back to the second year MBBS. That can you remember that how the menstruations stop, like can you remember that thromboxane 2 and prostaglandin, something like that? Yeah, this is if something wrong with that process, then a woman can get heavy bleeding because of some balance is not happening within the endometrium. That's mean the thromboxane 2 or the prostaglandin. Iatrogenic against IUCD. If someone has got IUCD, then they might get developed the abnormal uterine bleeding. I would take you with one by one the understanding of the physiology, pathology, and then how I'm going to tackle or manage these problems. Now, perimenopause menarche girl presenting with abnormal uterine bleeding. I mean, what does that mean? Perimenopause menarche means like menarche is like starting of menstruation. I'm talking about girls like 12 to 14, 15 range. It's a very common presentation to you all, I understand, because the parents bring their daughters saying, doctor, now my child or daughter developed or started first cycle maybe 6 months back, still not developed bleeding. Or she developed first cycle 6 months back. Again, there were no periods for 3 months. Now she's like flooding, like heavily bleeding. These are the main complaints. In puberty, as just after after the first menarcheal cycle or menstruation, still the hypothalamo-pituitary or uterine axis not properly started their function. Usually it takes at least 2 to 3 years to function properly. What I'm trying to tell, to someone to develop a regular menstrual cycle, at least it takes 2 to 3 years after the first menstruation, to have a proper cycle. And now you can see that as I said, now when you draw a diagram, like now in this girl, she has no periods January, February, March, and then start heavy bleeding like that. And what happened? This is we call period of amenorrhea. And I forgot to mention about the menstrual cycle. The most critical, the important event of menstrual cycle is ovulation. If ovulation is occur in each and every cycle, usually the cycles are regular. And as I, again, there are the follicular, in the uterines, the follicular, the proliferative phase and the follicular phase. That's the latter half. And the luteal phase is the constant phase. And what happened? This pubertal girls, they don't menstruating, and then they keep on secreting high level of estrogen within the endometrium, and then it increase the endometrial thickness. And then what happened? Then all of a sudden they lost the blood supply to the upper layers, and they start the bleeding, and then start heavy bleeding. And then how are you going to manage? First thing is, again, you have to ask about the menstrual history. Definitely, please ask about anemic symptoms, because I have seen in my practice, you don't believe sometimes the girls bring with hemoglobin of 4.5, 5 is not survival even. And then we have to admit, and then we have to transfuse the blood. It's a problem. Always, if a girl come and tell, because they don't know how much normal, how much abnormal. And they sometimes they don't tell to their parents, and they might be bleeding. And up to the point, sometimes maybe hemoglobin, as I said, 4 or 5, please ask about the anemia symptoms and do the full blood count. And if it is really is low line, I would say like less than 8, and please refer to a gynecologist, because then we have to assess, and then she needs sometimes, not sometimes, the blood transfusion as well. And then you have to ask about any other bleeding manifestations, like any gum bleeding, to exclude the platelet functions, or platelet disorders, etc. And do the general examination, as I said, the palo, basic things. And then you have to please do investigation like full blood count and TSH, right? Then again, how are we going to manage this perimenarcheal or girl bleeding? Now, as I said, you should understand the thorough knowledge about what is happening inside the endometrium of these girls. First thing is their estrogen level is high, and then they are getting more estrogenized, proliferative type endometrium. And then what they are lacking is progesterone, because the progesterone phase is not, they are inside in the uterus or the endometrium. That's why we should give the progesterone externally. Now, first thing is, you have to reassure that this is a normal thing, because, as I said, it takes at least 2 years to to have a proper menstrual cycle. Then you can start a tranexamic acid. TXA stands for tranexamic acid. Usually you can start with the 250 milligrams 3 times daily for 5 days. Or you can even go up to, if the girl is more than 60 kilos, you can go up to even 500 3 times daily, or even a 1 gram TDS daily for extreme cases. Usually, I would say like 250 to 500 milligrams 3 times daily is enough dose for 5 days. Again, the cyclical progestagens, usually we give 21 days, mainly 2 brands Sri Lankan. We have only 2 brands in Sri Lanka, like northosterone acetate, or the Primalute N and Nogest. We can give 10 milligram BD 21 days. And then because the reason behind that, the physiology behind that, we are artificially induced the progesterone phase in the endometrium or luteal phase. Then the bleeding will settle. And then don't need to continue throughout, just give the 2 to 3 weeks. And again, if she's developing same scenarios, you can repeat the same thing. And then other option, I would say, like a combined oral contraceptive pills. But problem is, most of the parents, they don't understand. There's a stigma. Okay, this is a contraceptive pills, and the parents don't want to start OCP pills. But actually, if we can start OCP or contraceptive pills in like a regular pattern, the bleeding, we can control the bleeding. And other thing is, you have to definitely give the iron supplements for them to enhance their iron level. Then again, the abnormal uterine bleeding, I would say like reproductive age group presenting. What I'm trying to tell in this heading, mostly like age of 25 to like 45 range presentation. Now I'm talking about the abnormal uterine bleeding women who belongs to age of 20 to like a 45 range. Causes like it may be due to polycystic ovarian syndrome or the endocrine problems, fibroid, adenomyosis, iatrogen like IUCD after insertion of IUCD, cancers, endometrial cervical, sorry for the spelling mistakes, ovarian, and then endometrial polyps or the perimenopausal bleeding. This is the, polycystic ovarian syndrome is very much common in Sri Lanka. The reasons why. Again, before I talk about polycystic ovarian disease, you should understand basic pathophysiology behind about the pathophysiology. The first thing is why polycystic ovarian syndrome occur. Again, according to the available, the research and data, we believe that this is a genetic plus environmental problem. If her mother has got a polycystic type ovaries, then definitely the offspring or the daughters has the definite risk that getting polycystic ovarian syndrome. plus the dietary habit and then environment. I would say like it's a dietary plus the lifestyle modification. You know, country like Sri Lanka, especially the Asian country, we consume much carbs in our diets and more carbohydrate, but we don't burn it. And then what happens? All these carbs go and deposit under the skin or in other viscera, like increase the fat amount in the body. And plus the sedentary lifestyle of today, most of the girls, they don't exercises, no, I mean they just attend the school and then after school classes, no extra activities, nothing, just a sedentary lifestyle. And then what happened because of the fat depositions, these the fat cells secrete so many chemicals, and then it affect the hypothalamus pituitary axis, and it reverses the LH-FSH pattern. Basically, it is an endocrine problem, and it up and down the LH-FSH ratio and increase the testosterone level. And because of that, they have developed many symptoms plus signs. Symptoms like, again, period of amenorrhea and periods not regularized, and sometimes they might not develop period 6 months, even ages. And then bald hair, and then pelvic pain, and then hair loss because of that high testosterone level, and then definitely the problem with the getting fertile or fertility issues. You can see the diagram of how polycystic ovary looks like, and as well as ultrasonically looks like how the polycystic ovaries looks like. And when they come to the GP setup, usually there are a few ways they can present. One thing is they might come up you all saying, doctor, my periods are not regular, and last period happened a couple of months back, not period. Now there's no period for last 5-6 months. And again, as a rule of thumb, any girl present to you with period of amenorrhea, I think better do the urine SCG next to the pregnancy first thing. And afterward, if it's really polycystic, and then you have to treat them. And if it's a menstrual problem, then you have to tell them about the disease. Probably this look like this, and then you have to educate them about dietary habits, especially less carb diet, and then exercises. That there are so many exercises we are talking about today, HIIT exercises, and then like aerobic anything. And then I think best thing is we can start combine oral contraceptive pills to regularize the cycles. And if someone has got a acne on the face, I think I would suggest you to start the size, like a Dian 35 preparations. I'm not promoting any the brands, but Dian 35 is good one, and as well as Yasmin is good combined oral contraceptive pill that definitely reduce this acne and other symptoms. And then if it's again heavy, you have to start with tranexamic acid, and then progesterone, again the 21 days progesterone, because they are also problem is not ovulating. That means keep on thickening of the endometrium, lack of progesterone within the endometrium. Then what do you have to do? What we have to do? We had to give the external progesterone to mimic the progesteronic phase in the endometrium, like 21 days. We can give the normotestrone acetate 10 milligram BD 21 days. And then, as I said, combined oral contraceptive pills, and then tranexamic acid accordingly. And please, I forgot to mention that if in your GP are doing great job in the primary screening, when they come to you, don't forget that this is they are more prone to develop diabetes, hypertension, and ischemic heart disease. You know the reasons why. Their metabolism, there's a problem with metabolism. Please bring them with OGTT and TSH at least to exclude the possible, at least IGT or impaired glucose tolerance. Sometimes they might already develop a type 2 diabetes as well. And please do that for the endocrine assessment. This is again common presentations, the uterine fibroids, or we call leiomyoma. Usually they are age of 35. Nulliparous women, it's not always nulliparous, sometimes even mother of 2, 3 can present with the fibroid uterus, and there's a genetic link as well. And usually they come with the prolonged menstruations, like as I said, now they said it's regular like that, and then they all of a sudden start heavy bleeding. But usually this type of bleeding is painless bleeding. That's an important thing about the fibroid. Usually is painless bleeding. Right. And then how am I going to manage the uterine bleeding for the fibroids? Again, these women complain painless PV bleeding, increase the flow, and basically they come up with a regular type bleeding. And then you in your setup, you can arrange a basic investigation like to check the hemoglobin, full blood count, and then you can order ultrasound scan, or you can do this examination if you are capable. You can do your abdominal examination to see any fibroid, or if I know that here there are many, I mean, obs and gynae doctors also there, OSCQs, they can do a per vaginal examination with a chaperone, and then if you detect enlarged uterus, then probably a fibroid, and then refer for a sonographer or radiologist to run a scan whether she has got a fibroids. And then again, we can manage with the cyclical tranexamic acid. That's mean just during the menstruation, give the tranexamic acid 500 to 1 gram. And now when you prescribe tranexamic acid for elderly, no, I don't tell elderly, like, reproductive age group, I'm saying after the age of 20, you can start 1 gram 3 times daily. 500, I don't recommend because it's not that enough. You can start the high dose, and then it has very good effect, and 50% blood loss. It has shown that clearly. If you start tranexamic in a high, like a adequate dose, we can reduce the blood loss by 50%. And again, some doctors, they start someone with a fibroid like as a cocktail, like mefenamic 500 TDS and tranexamic 500 TDS. Actually, if it is purely simply a fibroid, usual guidelines, they don't recommend the NSAID because there's not really necessity. Yes, if he has got pain during menstruation, probably combined with adenomyosis, yes, then there's a definite effect. Then you have to prescribe tranexamic plus mefenamic acid during menstrual period. And lastly, if she's coming to you, I mean, frequently not responding, then definitely you have to refer to a gynecologist for possible surgical options, maybe of myomectomy, or maybe if she's completed her family, then consider for the hysterectomy. This is another common presentation, adenomyosis. Adenomyosis, what is adenomyosis? Adenomyosis is actually a disease condition that you can see that in the diagram, that the endometrium is embedded within the myometrium, and then with the menstruation, this the endometrium within the myometrium also bleeding and causing the inflammation, and then they present with significant pelvic pain during menstrual period. And usually their periods are regular. Flow is increase the flow and regular period and pain as well. That's why I highlighted as a red color as a painful regular heavy period. They are coming with painful regular heavy period. They say my periods are regular, but now passing clots so much pain, and sometimes increase the duration. Most of the time they actually increase the flow rather duration with the clots. Usually, as I said, 35, 45. And if they come, if you see, I mean, clinically, okay, like a regular painful period, probably adenomyosis. And you know that adenomyosis, there are so many risk factors for the adenomyosis as well, like past cesarean section, past myomectomy, multiparous. They are more prone to get adenomyosis because of number of uterine insult happen during these cesareans and myomectomy, sometimes even normal deliveries. The management wise, again, cyclical tranexamic plus NSAID or mefenamic acid, we can prescribe during menstrual cycle. Like we tell them, okay, when you start your first day of menstruation, start this 2 tablets, tranexamic and mefenamic acid for 5 days. And then we can manage like that. Just ask them to get only during the menstruation. And then if not responding, technically first line management for adenomyosis is Mirena coil insertion. I don't know, some of the hospital, we know in Sri Lanka now situation is a bit of expensive, device. but some of the unit they have, in my unit, 1 or 2 IUCDs or marinas I shoot like a monthly basis. Anyway, if they don't respond, then you refer to the nearby hospital where the gynecologist is there. Then they might consider of inserting a marina coil. And the last option is a hysterectomy. And again, the endometrial polyp, this is the diagram. You can see what the endometrium polyps are like. These are like some polyp, some growth within the endometrium. Like this, how the hysteroscopically it appears. Now, that's why this is very much important when you draw a diagrammatic representation of menstruation pattern. Now, in this girl or woman, they have like a regular 4 or 5 days, but they complain some intermenstrual like spotting, like bleeding. These are the usual how they present, like intermenstrual spotting, and plus sometimes mucus discharge as well. And then if a girl or woman comes to you and saying, my periods are regular, but in between bleeding and spotting, sometimes mucus discharge. If you have facility, put a speculum. Sometimes the endometrium polyp come through the external loss, you can see clinically. And then please arrange ultrasound scan. And then the radiologist will see the endometrial cavity. And then if they notice that maybe some mucosal fibroid or endometrial polyp, then they will document it. Or otherwise, you can refer to the gynecologist. The take-home message is the abnormal uterine bleeding. Any woman who comes with abnormal uterine bleeding after age of 45, it is recommended refer to the gynecologist for a basic evaluation, because there's some significant percentage of women can present with, endometrial hyperplasia or worse scenarios, endometrial cancer. That's why we usually recommend you guys to refer. If someone is age of 45, irregular periods, and then risk factors like obesity, hypertension, diabetes, who are risk for endometrial cancer, please send them us to for the further evaluation, and then we'll do a scan, and then probably we'll do PIPEL, or sometimes hysteroscopy guided biopsy or DNC. Then the vaginal discharge again. Now, one of the common presentation to you, it range again. You might getting a school girl, or maybe 4 or 5 years old girl, maybe 20 to 35 range, and even elderly population. This is a very common presentation. Now, most of these discharges are actually physiological. Now, why that is physiological? Because if there's no irritation, no burning sensation, and if the color is like a whitish, transparent, not whitish, transparent, and asymptomatic, and probably is physiological discharge. I would now let's say it's a very common that the parents bring age 12 to 14-year-old girl brings saying that doctor, she's Sudayana. In Sinhala, Sudayana, they is really worrying about that. And what's the problem with this discharge? The reason is that just after menstruations or the menarche, there are the high estrogenic level of the endometrium. Actually, the cervical ectropion, like it's the endometrium comes towards the external os, and then increase the number of secretory or the endometrial glands, and then keep on secreting. And I don't know, that's still not proven. What I'll do, sometimes I prescribe at least combined oral contraceptive pills for 3 to 4 months, and then it reduce, because it reduce this high estrogenic environment, and then control some kind of the discharge. Again, I want to emphasize you guys that traditionally we do this mistake. Like in a pregnant woman comes with discharge, we just write a clotrimazole cream or clotrimazole pessaries, you put three days. That's normal most of the time. We call leukorrhea. That's a very common physiological discharge during pregnancy. Again, reason for that is again the mucosal discharge with the vaginal slough and epithelium shedding off, and then you all are mistakenly prescribing unnecessarily clotrimazole pessaries or screen. And if she's complaining, why, candidiasis symptoms, what are those symptoms and complaints? Burning sensation, itchiness, and curd-like discharge. Yes. Then the other thing is, yes, in pregnancy, candidiasis is also very common. But I would say, like, if 100 comes the vaginal discharge in pregnant woman, I would say 40% would be the candidiasis, but 60% of is a usual discharge. And again, you have to make sure that it's not a rupture of membrane. Be careful if some pregnant mother comes with the discharge. You ask about, is it like, you have to ask about clinically, like, is it a significant, like, is similar to passing urine, like, or clear fluids, or discharge? If it's a discharge, and then if it's itchy, burning, and curd-like discharge, you just prescribe clotrimazole. Otherwise, not really necessary. And if you're not sure, please refer to the obstetrician. And again, prepubertal girls, probably they come with vulvar discharge, mainly the vulvar vaginitis, and maybe vaginal foreign body, so maybe very rarely vulval trauma. The vulvar vaginitis is the main reasons. They are prepubertal girl, the lack of labial development, thin mucosa, and they are the pH within the vagina is a bit of alkaline, and poor hygiene, and then the obesity and cloth, the choice of cloth, those are the main things that why they develop this vulvar vaginitis. Now, I'm going to move to the last bit of lectures, like how to manage menopausal problems. Actually, in this few slides, I'm going to talk about postmenopausal bleeding and vasomotor symptoms, and how we can tackle those symptoms in GP setups, and then urinary problems. And actually, it's very sad that in Sri Lanka, most of the women, they don't understand they have reached the menopause, and then there are consequences and the effect, and then how they can manage. And then, because we have experience in foreign countries where we work, and then they are very well knowledge about menopausal stage, and then they know much better than sometimes, very difficult sometimes handle their menopause status, and then the management available. Because when it comes to Sri Lanka, it's 100% opposite. They don't know, most of them, they don't understand their menopausal stage and consequences. And I'm going to start about the little bit about postmenopausal bleeding. Menopause, technically we define if a woman has not developed period for 12 months consecutively, she reached the menopause. And after 12 months, if a woman comes with bleeding, we call postmenopausal. Please refer to the gynecologist, because there's a 10% chance that she might be a victim for an endometrial cancer. That's why we always recommend you guys to refer to the gynecologist. And in addition, it may be atopic vaginitis, the polyp, and then other causes as well. Again, the menopause and menopausal hormonal therapy, MST. Initially, we call it HRT, hormone replacement therapy. Now we will talk about MST. There's a new terminology we use about this hormone replacement therapy. Now, in GPs, I think it's a good idea. You should understand how to start the hormonal replacement therapy, because even gynecologists are also very reluctant to start hormone replacement therapy because of anxiety and fear of starting, because of the risk of cancer, mainly the breast cancer. Now, when it comes to, like, hormone replacement therapy or menopausal hormone therapy, according to the main studies in the world, if you have, after this lecture, if you are really interested, you can do the Google and search. The main study was WHI, there's a Women Health Initiative. It was done, I think, 2002, and then they found out that the risk of breast cancer is a bit of high in the women who started hormone replacement therapy. Plus, they increased the cardiovascular risk, like myocarditis as well. Now, later the critique was this study group, most of the women belongs to 60 plus, and then that's why they're prone to that type of heart diseases. But later they understand, again, then the subgroup analysis, they show that the women who exposed to progesterone is the problem with this breast cancer. I will show the next slide about the risk and benefit, like another meta-analysis we call the fluorospot. Again, before going to that slide, I would like to talk about, okay, now, what are the indications for starting hormone replacement therapy? First thing is you should get the proper history, because if, as I said earlier, the women, when they reach in the menopause, there's a transition we call like a perimenopausal. At age of 45, they experience like, shit, like period of amenorrhea, maybe 3-4 months no periods, again start heavy bleeding like that. Then now they are reaching the menopause, and then same times, because of this estrogen amount, lack of estrogen, and it affects their hypothalamus pituitary, and the thermoregulatory system in the body, and then they develop the irritative, really troublesome vasomotor symptoms. And then technically, not technically, because statistically they show that 80% of women suffer from the vasomotor symptoms most of the time in the menopausal. And then the irritability, the breast tightness, and those are the symptoms. And then same time they will get the vaginal dryness as well because of lack of estrogen, and sometimes the dysuria. So, again, before I forget, I would like to convey this message for you all, especially the GP doctors. Like, in a menopausal women, sometimes they come with frequently with dysuria. But you all are doing heap of, urine cultures back to back, all normal. Reason for that, because that urogenital epithelium is a estrogenized epithelium, and same thing happened to the uroepithelium. When they don't have enough estrogen in the body, they get thinner and thinner uroepithelium and exposing the nerve endings, and then when the urine comes and touches the uroepithelium, there's a burning sensation occur. And then there's no point of starting, doing culture. You have to do the cultures first, yes, exclude urinary tract infection. And then if you do examination, if you can see the atropic signs of vaginal, like thin vaginal wall, and then sometimes, urethral meatus epithelium is exposing. And then the best thing is you can start the hormone replacement therapy. Unfortunately, in Sri Lanka, it is recommended to start the local estrogenized cream. I think only one brand available. This called Primarine cream. As I know, only it's available in the the town hall union chemist. I'm not promoting, but you guys should understand, because sometimes your parents might have this problem. You can apply at least 3 to 4 months, twice daily. That definitely should be settled. And again, that's one complaint. Again, if they have vasomotor symptoms, then how are we going to start the hormone replacement therapy? First thing is, you understand, you should first exclude the possible contraindication, not possible, relative absolute contraindications, like, as I said, breast cancers, thromboembolism, liver diseases, and SLE. And then once you excluded those contraindication, then you can start the hormone replacement or menopausal hormone replacement therapy. Again, like, as I said, like, this is a replacement. You have to replace estrogen plus the progesterone. Again, what are we going to replace? We have to replace the estrogen, because estrogen is the problem of these vasomotor symptoms. Now, problem is, if you give only the estrogen to the body systemically, then definitely it affects the endometrium, and now you are asking or you are inviting to someone to develop endometrial cancer. Then you can't give a estrogen only preparation. Then you have to combine estrogen plus progesterone if her uterus is intact. Suppose if someone has had a hysterectomy, there's no uterus anymore, then you can give the estrogen only preparation. And then this is the basic way that we have to start hormone replacement therapy. According to the available market, only few things we have available. We call Femestone, again Progenova, and the Primarine cream. Femestone also, they have various preparations. Femstone mono, there's only the estrogen is available. And then Femstone to 110, there's estradiol valerate 1 milligram, and then cyproterone or the progesterone 10 milligram, and progino only the estrogen preparations. And but if you are if actually you guys can start hormone replacement therapy, but I don't. If you read more about how to start the indications and then the country indications, but unfortunately in Sri Lanka we don't have many good preparations like hormone replacement therapy. Like foreign countries, we have some transdermal patches, sometimes rings, so many ways we can address this postmenopausal issue. And now again, this is a very good slide. Now these are the benefits and the risk of hormone replacement therapy. Now can you see in your right side is in this table or the graph, you can see the zero line, and then the right side they talk about the benefit, and the left side they talk about the risk. They are talking about 1,000 women, 1,000 number of females per 1,000 per 5 years of use. That means this is a multi or not a one single study. This is a data grabbed or taken from many studies. We call it's a many this is data taken by many studies, and you can see in the right side now they have like the coronary heart disease and invasive breast cancer. This blue indicate only the estrogen preparations, and then yellow indicate estrogen plus progesterone preparations. And actually, coronary heart disease is has a benefit actually if we start hormone replacement therapy in age of 50 to 60, because we usually don't recommend start of hormone replacement after the age of 60. If I talk about one by one, I think it take more time, but you can understand that most of the time the benefit is so much high if we start hormone replacement therapy at correct time. It reduces the hip fractures, it reduces overall mortality, it reduces the diabetes, prone related diseases, and it reduces the coronary heart disease as well. And then problem always people think about the breast cancers. Again, if we start hormone replacement therapy, we have to get them a screen at least firstly 3 months and then 6 months like annually, and then they have to get their usual mammogram for every year. And then non-hormonal treatment, but we can ask them to start, do the exercises, yoga, regular exercises, and then SSRI preparation like venlafaxine, paroxetine, fluoxetine. It has some effect for vasomotor symptoms, and then some plant-derived estrogen preparations. My last bit of slides now going to talk about urinary problems, stress, and the overactive bladder. Stress, they come, and tell they leak the urine when they're sneezing, coughing, and then I think better you should refer them to the gynecologist. Again, overactive bladder. Again, what they come and they talk to you and they tell doctor that I can't go in a bus because when a bus start or maybe run 2 or 3 kilometers, I feel to urge, and then if I don't go to toilet, I might leak the urine in the bus. That's kind of very irritable, troublesome symptoms, this overactive bladder. And they have like nocturia, increase the frequency during the daytime, are the main symptoms of this overactive bladder. Overactive bladder is a kind of spectrum. It may be due to UTI, it may be due to postmenopausal changes or postmenopausal thinning uroepithelium, or the detrusor overactivity. The detrusor overactivity means that's mean detrusor muscles get unwanted contraction. It is very common in the postmenopausal age group as well. And then you have to do the basics, urine culture, ABST, the bladder diary, and then the lifestyle modification. And then in this, definitely you have to, if urine cultures and everything is normal, I think better to refer to the gynecologist to start a oxybutynin or tolterodine if it is a detrusor instability. Thank you very much. I think this is my end of my presentation. Any questions or anything that I can answer?
Thank you for your excellent presentation, sir. So there are some questions in the chat box.
Yeah.
So the first question is, so some girls complains heavy menstrual bleeding in the presence of normal TSH and not responding to mefenamic and tranexamic acid before the age of 18. How can we manage? Do all of them need gynecological imaging and other hormonal evaluation?
Which question? It's the first one. Can I see that? Regarding some girls complain heavy menstrual bleeding in the presence of is that one? No, the fans. Some girls complain.
It's in the chat.
Oh yeah, I can see that. Some girls complain heavy menstrual bleeding in the presence of normal TSH and not responding to mefenamic and tranexamic acid. How can we do all of them need evaluation? As I said, yes, because you know that if not responding for the tranexamic, actually now I usually like this age group, I usually, if not responding, we start a combined oral contraceptive pills. I think that's the answer for that. That again, if they don't respond, then you have to refer them for a further assessment, like maybe platelet disorders or other problems, because usually they should respond for the oral contraceptive pills and the tranexamic acid. But if not responding, yes, we have to refer them for a further assessment. And evidence that combination of mefenamic acid with tranexamic acid can reduce bleeding more than either drug alone. As I said earlier, uh, there's no evidence that combination reduce the blood flow, but tranexamic itself reduces the blood loss by 50%. Why we add the mefenamic? If she complains the pelvic pain, probably adenomyosis, yes, you have to add the mefenamic acid along with the tranexamic acid. But purely if it's a fibroid type bleeding, or if she has no pelvic pain, I don't recommend you all just start mefenamic acid for just a painless bleeding. There's no evidence that combination will reduce the blood loss. So can a 12 to 14 years old COCP as their bone growth is not complete? This is a bit of problematic area but you can start a smaller dose of pills, but again better to manage with nortestosterone and the tranexamic acid for girls who are belong to 12 to 14. It's a good question actually, because you know that estrogen, if you give excess estrogen, they close the epiphyseal plate, and then they don't develop the bones well, and then they might end up with a shorter stature. And my recommendation is like if you think that she has not like 12 to 14, give them as I said, cyclical progesterone, because the problem is in the menstrual cycle, they are not ovulating, and then they keep on secreting estrogenized, they are proliferating the proliferating endometrium because of high estrogen. And to knock off that high estrogenic environment, I suggest you, as I said earlier, give the nortestosterone for this girl. I would say 5 milligram BD for 3 weeks, and that's it. And then you add small dose of tranexamic in case if she develop heavy bleeds. Yes, COCP, it's not better to avoid the COCP in this age group, 12 to 14. PID. Again, someone asked about briefly describe the management of PID. PID are the pelvic inflammatory disease is mainly due to chlamydia and gonorrhea, and not only that, sometimes it might be due to other organisms within the vagina. And some doctors, they mistakenly treat PID for all pelvic diseases, but if she has, technically you should do the or endocervical swab and had to show either chlamydia or gonorrhea present in the samples, and then start the PID. But anyway, Sri Lankan context, we don't do that, but we start If you think, get the proper history, she's sexually active, multiple partners, any risk of getting a PID, then if she has no fever, then you can start with the doxycycline 100 milligram twice daily for 2 weeks, and plus uh, the metronidazole 400 milligram again 2 weeks, and Cipro 500 milligram BD for another 1 week. There's no 100. I mean, this is how we usually manage the pelvic inflammatory disease if it's suspect. But if someone comes with a high fever, with abscess formation, then definitely she has to admit and give the IV antibiotic, preferably IV ceftriaxone. Could you please briefly explain on the difference preparation of Femastone and the use of? Okay, someone has asked about the Femastone. I'm not promoting a medical, the brand, but problem is this is the only preparations available in the market in Sri Lanka. They have few preparation, Femstone Mono, and then Femstone 110, Femstone 210, and then Femstone Conti. These are the 4 preparation they have. Femastone mono, that means they have only the estradiol valerate. They have 1 milligram preparation as plus 2 milligram preparation. As I said, if someone has no uterus, then you can start Femastone mono. You can start with the 1 milligram and see whether she's responding her, vasomotor symptoms. If not, you can go up to 2 milligram. And I forgot to mention the hormone replacement therapy. Actually, we can even go up, can give continuously 5 years. That's a usual recommendation. And your question, the Femstone preparation, again, the 110 is it has 1 milligram of estradiol and 10 milligram the progesterone. Again, that is it's a sequential. Again, actually, I didn't go much about this. When you start the hormone replacement therapy, perimenopausal, that's mean if someone has not stopped menstruation yet, but you feel that she's in a perimenopausal plus vasomotor symptoms, then we call sequential hormone replacement therapy. That means you are mimicking your normal menstrual cycle. That means you continuously give the in Femastone 110, they have continuous estrogen preparation, and last 14 tablet, they have the progesterone. That's why we call sequential. Sequential, they have 2 preparation, 110 and 210. If she is not responding 110, then you go up to 210. And let's say like if someone has sequential for 2 years and then menopause for more than 1 year, then you can start continuous hormone replacement therapy. They are called Femstone Conti. That's mean they give the continuous estrogen plus progesterone throughout the month. I think you're clear on that. How to increase the fertility? Then they ask about how to increase the fertility in PCOS except lifestyle modification. Fertility, first thing is the problem. I think when you refer the guidelines or the recommendations by the NICE and other accepted reproductive guidelines, first thing is lifestyle modification. You ask them to reduce the weight, and the NICE, what the NICE talk about, NICE guideline. If we can encourage them to reduce the weight by 5%, by 5%, there's a chance that they ovulate. That means weight reduction very much important to increase the fertility. And other option is we have to start fertility drugs that in Sri Lanka we have either letrozole or clomiphene citrate. And we usually now current recommendation is to give the letrozole, because that's called the reason for that is they have shown that it's a monofollicular development. I think you can understand what that means. Monofollicular means now that's why that last this artificial reproductives is a problem with the multiple pregnancies, twins, I mean sometimes triplet, and recently 6 baby delivered in a Castle Street. There's a problem with this ART or artificial reproductive technology. And like when it comes to ovulation induction, I usually start the letrozole at 2.5 milligram BD twice daily, BD day 2 to day 6, and then get them to day 12 scan. And then if you can see the follicles more than 16 or 18 to 20, then you can give the the beta HCG, either Ovidac or Pubergen, and then after 24 hours time intercourse or intrauterine insemination or IUI. That's how you should practice with ovulation. enhance the fertility. And in addition that, there are other preparations. I'm not sure about that. This called Arrowhead, or there's a some preparation. They say they will increase the ovulation. I'm not sure about that. Even the data, so it's very gray area. But those preparations. How to manage premenopausal bleeding? Yes, again, premenopausal mean again, you know, if someone, as I said, like when a girl starts bleeding just after menarche, first 2 years is irregular because of, I mean, because ovulation is not happening well or not occur. And when they're in the premenopausal, when they reach the menopausal age, their ovulation is again, the ovulation process is not happening, and because of that, they start bleeding. Then management, again, as I said, because the problem is again they have estrogenized epithelium, give them testosterone acetate 3 weeks cyclical. Give it 3 weeks and then ask them to, okay, wait, if she's developed again, give the same combination. But if you feel that is bleeding is heavy, high, as I said, above 45, but if she's coming, regular to you, please refer to the gynecologist to exclude the possible endometrial cancer. And in addition, you can add the tranexamic to reduce the blood loss. Which context we should prescribe a bromocriptine for stopping milk secretion, and what is the dose? Actually, cabergoline is the drug of choice for stopping the breast milk. I think it was 0.5 or 0.2, 0.5 milligram single dose. If you start bromocriptine, I'm not sure about the dose. You please refer the BNF. According to my memory, it's 50 or 100 milligram. Because I have not been prescribing bromocriptine for ages. I just prescribed the in my unit the cabergoline. Some girls are complaining very severe abdominal pain and body discomfort even prior to menstruation, but not outlasting menopause. No menorrhagia, sir. Could that be endometriosis? But is usually outlast. Yeah, sometimes, you know, the endometriosis. Yes, sometimes even endometriosis may be asymptomatic. Sometimes endometriosis, usually this outlasting menstruation type of history usually comes with adenomyosis. And when it in endometriosis, yes, they definitely during periods they complain significant low abdominal pain, and sometimes even in between menstrual cycles also they might complain abdominal pain, but they may be having I can't say because no yes answer for this. We have to evaluate it, but if it's significantly she's getting pain, probably she has got kind of pelvic endometriosis. Better to get seen by a gynecologist. Sometimes she might need a laparoscopic laparoscopy to rule out the endometriosis. An effective treatment for hirsutism. Hirsutism is, as I said, cyproterone acetate based PCOS combined pills are really good, like DAN 35 or Yasmin. And in addition that, there are some skin laser treatments for those things we are not going to do, actually speaking, because we refer them for maybe plastic surgeons or the dermatologists talk about to prescribe some preparations to reduce the hirsutism. There are various preparations to remove the hair, like hair creams, and then some gels, but technically, when we start DAN 35 or Jasmine, we have seen actually some kind of hair growth rate. It reduced the hair growth in the body. But if it is really excess, I usually refer them to the dermatologist. Is there a place for metformin in PCOS and subfertility? Yeah, some of the studies they mentioned adding a metformin with the clomiphene citrate, it increase the fertility rate. Again, it's very controversial to answer this. Again, some studies say there's no, because if you think, that's why I said if someone has come with PCOS, we always my advice is due to OGTT. And if the OGTT shows impaired glucose tolerance, yes, you add the, I would say like fasting blood sugar comes 116, like IGT level, then you add the metformin. Otherwise, not really necessary to add in the metformin because it has, I mean, some kind of side effect like a gastric irritation, dyspeptic symptoms. If you see or like acanthosis nigricans and some insulin resistance in the body, you better to start metformin. It might help to or increase the chance of ovulation. So when managing perimenopausal bleeding, both on examic 5 days and same day. Yeah, because when they come to the perimenopausal bleeding, we usually start yes, same day they can start testosterone and tranexamic acid, and tranexamic for 5 days and then testosterone for 3 weeks. I think I answer all the questions anymore.
Those are the questions in the chat box.
Yeah.
And we have received some questions in the pre-survey. However, you have answered most of them during the lecture.
All right. Okay.
So our sincere thanks to Dr. Dharshana Somirathne, consultant obstetrician and gynecologist, Best Hospital Walasmulla, for his excellent lecture and the precious time.
Thank you very much.
Thank you, sir.
Thank you. Bye-bye.
Then, dear participants, please find there are 2 links in the chat box. First one is for the CPD certificate form offered by Shri. The other one is for the CPD points offered by Ministry of Health. So you have to fill both of these Google forms. Then you can receive the e-certificates and the CPD points as well. Thank you, everybody.